we are the community pain service for Lancashire Care Foundation Trust. And we've been working in community pain probably for the last 15 years or so. Our base is mainly in Ainsdale, and some of you may have been there. We have satellite clinics out in Southport, and we used to have a satellite in Formby, but that's not running at the moment. But our clinic base really is in Ainsdale. And our real, the thing that we really want to achieve is to help people manage their pain, potentially in the long term, and live as well as possible with pain. We also want to help people minimise their pain as much as we can, so we focus a lot on diagnostics and trying to understand pain. And when we drill pain down and start to really understand it, we can see that there's potentially lots of different mechanisms that gives us kind of little angles in on managing pain. Because as many of you will know who are living with pain every day, it's not something that's simple. It's not something that one kind of magic bullet will fix. And so really that's what we're here for tonight, is to try and discuss that and to try and understand a little bit more about how pain works, so we can all individually kind of maximise our own pain management. As Becky said, we're going to be doing a kind of card-based system, so if you've got questions, please scribble them down, and people are going to be circulating. So stick your hand up if you've got a question, and people will circulate, and they'll collect the card, and we'll do the questions later. Mark, can I have to get the first slide? Thank you. I feel really weird. Mark's my slide person tonight. I'm normally doing it myself. So anyway, so the session objectives tonight are for myself and also Graham and I are kind of going to talk your way through this, is to understand and look at how normal pain works. Then we're going to look at the nervous system, how that can maladapt and make pain stay. We're going to focus on what makes our pain, what are the ingredients that kind of make up our pain, and also how our thoughts and feelings can change the intensity of pain and the impact of that. And that can give us sometimes little ways into managing pain. Thanks, Mark. The really important thing is this is what pain does, and we know that this is what it does. Everybody who is involved in pain and who's experiencing pain knows that this is what it does. Next one. So, we're going to do an example. We're going to start off our session kind of doing an example. And does anybody do DIY? Yeah, stick your hand up if you do. Hopefully not an injured hand. Stick your hand up if you do DIY. One or two people. I've kind of put a tentative hand up because I don't do DIY much. But anyway, you can imagine we're doing a bit of DIY. We're hammering a nail in, okay, to a wall. And if you're like me, you might be a bit clumsy. And so we're going to hit our thumb with our hammer. What goes through our minds just at that point? Anybody? Swear words, yes. I'm glad somebody's jumping in with swear words. What else goes through our mind? Ow. Ow, yes. Anything else?
Expletives.
Sorry?
Expletives in great
exactly, expletives, yes. Do we feel the pain straight away?
No.
We don't, do we? Do we know that we've done it pretty much straight away? We do, don't we? So somehow there's a bit of a lag there. And that really is explained by our nervous system works on, I don't know if there's anybody kind of, my age, broadband and dial-up for internet. Can you remember this kind of old modem which kind of hisses away when you dial up on your modem? Basically, the connection is really slow in the pain system, and it's quicker in our normal nervous system. So that kind of explains why we can feel it happen, but we don't feel the pain straight away, because it's chugging its way along our nervous system. But it gets there. So anyway, we've hit our hand, we know we've done it, and we've kind of had a few expletives. What else do we do at that point? We recoil, don't we? There's a reflex in there. That's our kind of physiology kicking in. What else do we do?
See whether you're bleeding.
Say again?
See whether you're bleeding.
See if you're bleeding, yes. Anything, there's something over there.
Stick your thumb in your mouth.
Stick your thumb in your mouth, exactly. Cold tap, anyone? Yeah.
Yeah.
Okay. Yeah. Why do we do these things?
Make it feel better.
Make it feel better, exactly. Because kind of Mother Nature tells us that if we do these things, then it kind of makes it feel better. And we'll drill down the physiology of that now. I'll have the next one. Okay, so if we're looking at the body's sensors, we've got the posh words there. We've got mechanoreceptor, thermoreceptor, and chemoreceptor. The mechanoreceptors are the mechanical sensors in our body. They sense movement, they sense pressure, And they're kind of divided up into kind of really low threshold ones that will just trigger anything. So an insect crawling over the skin will trigger a low threshold receptor. And then there's the really high threshold ones, which are kind of like the Steven Seagal of our receptor group. And they'll only kick in, like the Marines, they'll only get mobilized when it's hitting the fan. And so if we get like really knocked or really banged, then we get those receptors kicking in. And there's anything in between. So the whole dynamic range of receptors. And it's the same for our thermoreceptors. They'll sense whether it's within the normal operating range for our tissues. And they'll just give a little bit of information to our brain if it's nice. If it's way colder or way hotter, it'll fire away. I don't know if you've done anything like I've done. I should learn from this, but you stick your hand on somebody's kitchen, somebody's oven when you go to a kitchen party, and like you kind of recoil really quickly. And that's our reflex system. That's telling us that there's something happening in our periphery that may threaten us and may damage our tissues. We've got at the bottom the chemoreceptors, and they're kind of our chemical system, and that's kind of our primitive one from when we were creatures in ponds, and we have to be able to sense what's going on in an environment, and so we move away from that environment if the chemistry is different. We don't use those so much now because we don't really exist in ponds too much now. So that's kind of how our sensors work, and they'll send a message, they'll send a message down these nerves, and the nerves will plug into our spinal cord, which is obviously in the centre of our back, and they'll send a message from the spinal cord up to our brain. Thanks. So, the posh word for sensing pain is nociception, and this is the body's way of presenting information about a potentially threatening situation to our brain, to our nervous system, to consider it a bit more. And that consideration may be, yeah, that's okay, it doesn't matter, it's not really going to threaten us. Well, that could be this is really, really damaging, this is terrible, and we need to get out of there. It may be really threatening for us. So that's kind of what our brain does in deciphering this. Can I have the next one? Now, the really important thing about how we understand pain, and I guess we've moved a lot in the last 10 years, particularly with pain research, is our nervous system is the main thing that generates pain, and that we appreciate pain with. We understand our pain, we feel our pain just within our nervous system. And you need a brain to feel pain, because our spinal cord, which is the filtering mechanism which we talked about, that sends the information up to the brain, that doesn't feel pain. It just sends noughts and ones. So it sends data up to our brain, and it's our brain that's the really important thing that kind of understands what's going on. Now, to do that, all that sensory information goes into the brain, but it combines it with a lot of cognitive information about what's going on at that time. Now, I don't know if you can see this, because the writing's a bit small, but it's about our beliefs, our knowledge, it's about our expectations, and whether this signal that's coming into our nervous system represents a threat to us. It's about social work, our work environment, cultural factors associated with the sensory information that's going in, our previous experience, which is dead important, because if we perceive that what information we're getting sent and the sensory information that brings is going to damage us, we condition, our nervous system conditions itself into generating more of a pain response. So all of those factors there generate meaning to our pain. And they can generate either expectation or they can generate anxiety, may or may not do. But they all combine for us to then appreciate what our pain is. So you can see that our pain in normal circumstances is a combination of sensory inputs and a big long list of cognitive factors, and it's all mashed together. And the output of that will be how much pain we experience. Does that make sense? Does that surprise you? There's a few shakes of heads here. I think we're really starting to understand and drill down how neurophysiology works. And so I'll just go through that again. Our pain that we experience, whether it's acute pain from an injury, whether it's chronic pain, and we've had it for 20 years, is a combination of sensory inputs from our spinal cord, which has got sensory inputs from all the nerves and the sensors, and a mishmash of a big long list of cognitive factors that tells us what our brain is doing and what our experience is there and then, and that will decide how much pain we have. We've probably often heard of situations where people have been in kind of horrible situations like an accident or something like that, and they might say, I didn't feel pain at the time. I just needed to get out. And so if it was in an accident or, whatever situation it was. And that's where our brain kicks in because it can prioritize stuff. And so all of that sensory information saying, you've damaged yourself here and it could be something quite serious, that's irrelevant. We need to get out of that situation. So our brain can prioritize stuff and gives a response to say, I don't need you to feel pain now, I need you to get out. And so it's only later on that all those things start to kick into place and we start to feel the pain a bit more. So, Mark, can we have the next one? Thanks. So let's go back to our example. We've hit ourselves with the hammer. That's all very interesting work. We've hit ourselves with the hammer and we've put our thumb under the tap. And we said that there was this kind of, we'd stick it under the tap, we'd swear a little bit perhaps, we'd shout a little bit. Those are emotional kinds of responses to pain, the swearing and the shouting and the feeling really annoyed. But there's a sensory response to pain as well. If we stick our thumb under the tap, what kind of sensors? Actually, Mark, can you go back? That one there. We've said that we've got mechanical sensors and thermal sensors there. If we stick our hand in the cold tap, what ones are we stimulating by doing that? Thermoreceptors, yeah. And we're probably stimulating a bit of mechanical receptor as well, feeling the hot water, feeling the cold water on our thumb. If we were to clone ourselves and do two versions, one sticking a hand under the tap and one looking at it, who do you reckon is going to have the more vivid pain experience? Second? The one looking at it, yeah, exactly, because the reinforcement visually of I've damaged my thumb and all those cognitive things really are potent in driving those beliefs and expectations about our pain. Whereas if we stick our hand under the cold tap, we've got lots of other information going into our nervous system to distract our brain, like cold stuff hitting our thumb, and we may be looking out the window, looking at the kids in the garden, something like that. All of that information then is not allowing that pain program that's just started running any airtime in our nervous system. So it's about kind of distracting our nervous system a little bit. Mark, can you get on with it? Thanks. So, on the next one, yeah. So, let's move things forwards 2 days or so. What's your thumb looking like now? Swollen, exactly. What else? Black and blue. Yes, swollen and black and blue. But why does it do that? Because of the blood. Yeah, exactly. And protection, exactly. Protection. The swelling that we get in our thumb is a big inflammatory response because our body has got this amazing system, the immune system, and it polices what's going on in our body. And it swishes itself around in the blood and it kind of checks everything. It's like the police. It kind of just checks everything, patrols and says, yeah, that looks all right, that's fine. And then when it encounters something that's injured, it says, we're going to have to get something in there. We're going to have to call in the brickies for some structure, the sparks for some new wires, some nerves. I need to get the plumbers in for some blood. So it fixes it and it coordinates this response. And that response is coordinated by chemicals and swelling and stuff like that. So there's a big, big building site going on there. We know that when that building site's active and all those chemicals are there, it stimulates, or rather it reduces the threshold for these sensors firing. And so previously those sensors, you'd have to give them a bit of a stoke to send the pain signal. But now they've got this chemical soup around them. These sensors are really, really sensitive. So you tap your uninjured thumb, it's just tapping your thumb. But if you tap your injured one, it's really sore because those thresholds have now dropped. So if we move on, thanks. So the other bit of our physiology is what happens when we get into the nervous system. And this is a picture of our spinal cord. So these are the nerves that come into our spinal cord and it kind of sticks into our neck or in our back or wherever it is. So these nerves kind of join in. It's a bit like a big kind of connection box of all these cables. And at that point there, the decision is made in the spinal cord. Do I stop this signal dead? Do I send it up to the brain? Or do I turn the volume up on it and turn it up louder? So over a long period of time, if that bit of our spinal cord is bombarded with signals, then that starts to get irritated and it starts to reduce its kind of thresholds and it starts to send loads of stuff up to the brain that it wouldn't normally send up. What do you reckon our brain would sense if that was the case? Anybody? Overload, exactly. So we get kind of pain overload in our systems, and so we get more unbridled information going into our brain. And our brain struggles to make sense of all that. It does its best, but it struggles. So this is what you would term the first bit of central sensitization. Central being central nervous system, so the spinal cord bit, and sensitization meaning it can't filter things properly, so it's sending up all sorts of information. Now, we can see that there's a kind of these little slices of, these are bits higher up our spinal cord, and this is starting to get to our brain stem, and these are bits obviously in our brain. So all these connections now start to feed into our brain, and there's a big network going on. It's a little bit like a computer network. And if you look at these kind of posh scanners that we've got kind of now in research, they can see how active the brain is in somebody who's had pain for a long time and somebody who hasn't had pain, and that the brain is hugely active. It's like a computer network that's alive, it's kind of lit up. And so it really highlights that pain doesn't just get into one bit of our brain, pain gets everywhere in our nervous system. And so we start to become more sensitive to things like noise, we can start getting sensitive to light. Normal stuff just doesn't feel right. So when we move, it just doesn't feel right. Sometimes we're a bit unstable, just don't quite know where we are. And you can start to get remodeling within the nervous system. So our sensory system as a whole just doesn't function right. So as time goes on, all of these changes can occur over weeks and months. Now, we've talked a little bit about sensitization, and this is again important in things like osteoarthritis, because traditionally we thought osteoarthritis is a degenerative condition. We now know osteoarthritis generally, it's a repair of our body because the joints sense that there's little microtraumas going on in our joints. So it mounts this immune response, as we talked about before, the injury response to try and heal it. But in doing that, in the little microtraumas of our joints, it sensitizes those nerves that are in the joints. So if you think of the little repairs that are going on over months or even years, those repairs can sensitize the tissues within the joints. So we can start to get joints, even if they're not particularly kind of irritated inside, the nerves have become sensitive. So that's one of the reasons why we sometimes recognise that we have chronic pain in osteoarthritic joints, not because it's inflamed, but because actually the nerves are more sensitive and more jangly. So what do we think a little bit about arthritis? Can you move on again? Thanks. So we've talked a little about the spinal cord, we talked a little about the nerve, about the brain rather, and we know through, again, you won't be able to read this, sorry, it's, the print's too small, but there's, again, lots of studies that are showing that our brain becomes highly sensitized in response to injury sometimes. So it says on here, osteoarthritis causes central nervous system sensitization. We just discussed that. What else? Brainstem significantly involved in nociceptive filtering. What that means basically is our brainstem's got a kind of inherent protection in it for pain, and it kind of sends messages down to our spinal cord. Can we just go back to this one here? We've got a system here, this green fibre, which you won't be able to see too long, but this green fibre, basically, it sends a message down the spinal cord to say, shut it off. I've had enough. But in chronic pain, that system doesn't work very well. And so we don't get that protection to our nervous system. And it's really important because this system here, the descending inhibitory system, that's where a lot of our drugs are targeted. So things like opioid drugs like morphine, if we don't have a particularly good descending inhibitory pathway, then drugs like that won't work. So it's, again, it kind of starts to explain why medicines have really limited use sometimes in the management of chronic pain. I'm going to, I think probably, Graham, do you want to pitch in?
Probably introduce myself first. So I'm Graham, one of the physiotherapists who works in the pain clinic. So yeah, just sort of carrying on. I suppose I'm going to talk a little bit around management more so, of sort of like persistent pain. And sort of carrying on what Chris was talking about. I think when I see persistent pain, I think the big difference is that, like when Chris was talking around before, when you have an injury, I think the big thing with that type of pain is really consistent. So if you sprain your ankle, so you think about it every time you put your foot down, it's painful, until eventually once the tissues have healed, the pain goes away, then you get on with life. And I think with that type of pain, it's relatively easy to deal with because even though you experience pain, you know there's an end point. But I think from working in pain for the last sort of 5 to 10 years, I think the presentation of sort of persistent pain is completely different. And I think the things that I sort of often see is that it's unpredictable in terms of one day the pain can be okay and the next days it can be sort of really, really intrusive. And that can go from activities such as bending your back. You bend it one day, it's okay, and the next day and that's incredibly frustrating. We see that really, really small movements hurt. So movements, what you probably can't cause much damage to your body, but your system sort of amplifies the effect. And then you feel things like pain changes quickly, not just with movement, but also emotions and how you're feeling. And I think the longer the pain goes on, I think the association between something structurally wrong with the body and pain, it goes further and further away. And I think I've put on the bottom there that pain, with persistent pain, is no longer an accurate measure of tissue damage. But I think as healthcare professionals, especially myself training as a physio, we were sort of trained in this model. You found what's wrong with the tissue, you treat the tissue, the pain goes away and you get on with life. And I'm sure that there's many of you who've sat up there and you've had some physio input. It's helped for like 2 or 3 days, whether that's just things like acupuncture, massage. And I think going back to what Chris was talking before, you're tricking the nervous system a bit. So when someone gives you a massage, you stimulate the mechanical receptors. So less of the pain receptors are sort of getting up to the brain system. So you're sort of tricking it. But unfortunately, that only works very short term. We know that pain is a lot more complex. And I think it's my job that the persistent pain, and Chris is talking about what's happening with the system, but I then go a bit further. And when I see people who sort of live with pain, these are the things what I see. I see that people sort of change how they move because it becomes incredibly difficult to move. You don't want the pain. It's a horrible, horrible place to be. So people can get a little bit frightened to move. So we don't bend our back. And then over a period of time, you can become more deconditioned. And then it's sort of, as a consequence, you can't engage in activities of things what you enjoy in life. And again, you can't do the things what you enjoy in life. Reduce participation and ability to work, physical, social, and it becomes, you can sort of see, it's just a building up, it's like a vicious cycle really. And again, it can lead to isolation, reduced confidence. And I think what's really, really interesting when Chris was talking about when we're processing pain in that brain area, go to the next slide, that when pain goes on for a period of time, beliefs change over time. So you've had pain for sort of 20 years and you ask someone what's going on in their head. From my experience, they don't say, oh, my nervous system's more sensitive. Often it's, I've got arthritis. And the really worrying thing is often that comes from us as healthcare professionals, because unfortunately, 10, 20 years ago, that's what we were thinking. But our change in how we're looking at pain has changed massively. So you say this, again, I ask people, you think that arthritis is going on, and you ask them, what, the spine's crumbling, and I wouldn't move if that's going on. But hopefully, like when Chris is talking about, that is not the case. This is about the nervous system. And things like the brain, when it's sort of processing how much pain we experience, it looks at things like what's going on in your social life, how you're feeling, and over time, this just goes in a vicious cycle. And I think we need to move away from sort of treating the symptom of pain by putting needles in it, by massaging it, by putting manual therapy, putting hands on people, to sort of retrain this nervous system. Okay, so I'm going to bring Chris back in now, because as you can see, pain's really, really complex here. And the most important thing to start managing pain is the assessment. So if you see that all the different things what can sort of influence pain, if we just look at one part of that picture, you're missing so many other things. So, and I don't know if you've heard of it, we talk about managing pain and biopsychosocial assessment. I'm going to bring Chris in to talk about the stuff.
Yeah, that's great. Yeah, I think, as we've said, that the kind of the thinking of pain has changed a lot over the last 10 years. And this, you may have heard this term, it's kind of used quite a lot, biopsychosocial. That's what we make. It kind of splits down to biological, psychological, and social. And it kind of feeds into what we've been talking about. But the biological bits, really are to do with disease, to do with diagnosis, making sure that things are fully understood. And I guess, as Graham said about osteoarthritis, you know, that's often one of the things that we put pain down to as clinicians. We can say, oh yeah, arthritis. But we need to make sure, obviously, that there aren't any other conditions and there aren't any other things that are implicated in pain. And I guess that's the job of a diagnostician, like a specialist like Graham, physiotherapy, or kind of, you know, from the medical side of things. We know that some medical conditions make pain, and things, you know, kind of inflame areas, things irritate nerves. And so we know that all of those things occur, but we need to kind of understand how much of this is down to the biological bits and how much is down to kind of sensitization through those mechanisms that we talked about spinal cord and about brain. That's one of the big challenges in pain, because generally speaking, pain is a bit of a mishmash of all of those. So our old kind of way of managing pain tended to be things like, as Graham says, put needles in it, trying to put steroids in or inject, or medicines, this kind of thing. And again, it doesn't kind of, it's not the full picture given what we've been talking about. And so really what we focus on a lot when we've understood the diagnosis is about kind of how our function can kind of play a part in our pain, whether it helps our pain, whether sometimes it can hinder our pain. And that's really how we kind of drill things down from the kind of functional side of things with Graham, physios, therapists.
So with the assessment, like Chris says, is that looking at the biology, of course, and making sure that it's not the things causing the pain, but a big part of the assessment is understanding the psychology, so understanding what sort of people's beliefs are, understanding what their cognitions are, getting an understanding of how they're feeling living with pain. Because how you're feeling with pain can amplify that effect quite significantly. And I'm sure you've all, who's experienced pain, at the times when it is tough, when you're having a bit of a downtime, pain will be intensified. And often you might have not done anything physically to sort of increase the pain, and that's something you can see sort of quite regularly. And also looking at the social aspect of it. So when you get assessed with pain, people will ask you about sort of what's going on in that other aspect of your life. And I think what sort of underpins it for me as well, sort of working in pain and working with psychologists as well. I think as physios, we always sort of come as we're the experts and stuff like that. And I think what I've sort of developed in the last couple of years is finding out what's important to the patient. Because what's important to every one of you living with pain will be different from person to person. So I'll ask most people in my clinician, what are your best hopes of coming to the pain service? And I think most people say I want to reduce my pain. But the next question, what's important? What will be different if the pain's less? And often that is sort of giving some meaning back in life, whether that's being a better grandfather, whether that's being a better son, whether that's being a better friend. And that becomes the target, rather than sort of focusing on trying to reduce the pain. You have a focus, you have a direction. And often when people get engaged back in those activities, that normally has a pretty good thing with people's mood, and that can normally have a positive impact on the pain experience. Okay. So as you can see, sort of basically the way of sort of we're looking at managing persistent pain, it's about retraining this pain system. And I think we've got enough evidence these days that the nervous system is, we describe it as plastic. We describe it as plastic, and it's got its ability to remold itself. And if you go back to that slide, the brain before that, this is what sort of fascinates me, expectations and consequences about pain. And I think living with pain, I think, like you said, you've probably heard it, people can come quite fear avoidant, sort of quite worried about sort of doing certain movements and become incredibly protective. So if you watch someone with back pain and you watch them pick a pen up from the floor, often people avoid bending their back and bending their knees. But you can create new experiences and teach people to move in different ways and do it gradually, and teach people to do perhaps with less tension in the body, and it's not as bad as you think. You can create new experiences, so when you do these new movements in the future, your brain doesn't see it quite as a threat, so you're reducing the threat and you're producing a safety mechanism.
Can I jump in
there? Yeah, Chris.
Because I'm going to turn it down a bit even more. Because I think there was a really interesting, there's been a couple of really interesting studies that focus on just what Graham said about kind of the avoidance of activity, because it's inherent in us. If something's painful, and we don't do it because it's kind of logic for us. really, but there's some really important studies that have shown, even when we look at the image of somebody doing that, if, for argument's sake, we've got terrible back pain that's been with us a long time, even if we look at somebody else making those movements, it can increase the intensity of our pain. So it's really, really complex, this, about how we think about pain and how we perceive pain. It's fascinating kind of, fascinating kind of physiology. If you're in the middle of it, it's not fascinating, but from the point of view of understanding how our pain works, we know that these factors are so important. And this is one of the reasons why we talk about retraining our nervous system, retraining the sensory side of things. For us, our brains not to kind of join those dots in the way that they have done previously. It's about kind of being able to do certain movements and not being in the same kind of concern that it's going to flare stuff up. And there's different ways of doing that. Retraining the nervous system, which again, Graham's probably, that's your expertise really going in.
What is the next slide? Next one. So what we're going to do now is, I think it's in a very short period of time to discuss what's the magic way about managing pain. It's incredibly difficult because it's really tough, and it takes a lot of courage from clinicians to try and help people with pain, and it takes huge courage from patients as well to sort of perhaps looking at managing the pain in a slightly different way. So I suppose in my mindset now, I'm going to sort of give a case study of someone who came into our clinic about sort of 12 months ago, and just talk about his journey to sort of how he was managing his pain and how we sort of changed perhaps the way he was managing his pain. And this was a gentleman who came into our clinic, and he was a 60-year-old gentleman, and he had a 20-year history of lower back pain. And what was really interesting, I hadn't even started with an injury. And I don't know how much people know about back pain, but 50% of back pain doesn't even start with some sort of injury to the body. But often we go through a system where we treat the back as it's injured. Okay. So he got referred for an MRI scan, and there was nothing sinister on it. He was told there was sort of like normal age-related changes, arthritis. And then his best hopes of coming to the service was, when again he said to me, it produces pain, but that looked about engaging back in some meaningful activities like gardening, because that was really good for him to relieve stress. That was to get out more and see his friends, because when he used to see his friends, he didn't think about the pain as much. So, next slide. So what was really interesting to me, I think the first thing I looked at is, I asked him, what do you think's going on? And the things what he'd heard in the past, he'd been advised that he had arthritis. And asking him what that meant to him, his exact words was, I thought my spine is crumbling. So you can obviously think that is a huge threat going into his body. If anyone's system thought that was happening, your body, you're going to become more protected. You're not going to bend your body. Okay? The things he did in response to that, well, he avoided moving his back. He stayed indoors, and his way of managing the pain was taking medication. That was his when I asked him, what are your main strategies for managing this pain? It was medication. Things he thought and what he believed. Well, in his mindset, he thought the pain he was experiencing was equaling the fact that his spine is deteriorating over age. And eventually, within a period of time, I said, well, where do you see yourself in 5 years? And he said, I see myself in a wheelchair. Places he went, well, when his back pain flared up, as you think, his only way of managing his pain was taking his pills. So when his back pain flared up, he went to A&E because he was hoping they'd be able to give him more pills. Okay. And people in his life, he was seeing a physiotherapist he would see on a regular basis, and he would have a massage and then manipulate his back, and it'd give him very, very short-term relief, 2 or 3 days of relief, and then he'd be back to normal. And the things happening in his body, well, not surprised, he felt really anxious because he said to me, I've got no control over this. I've got no control. The only way I can control this pain is through this medication. And not surprisingly, he said he was depressed because he was doing nothing like what he enjoyed, the things what he previously enjoyed. So management, the first thing we did, we discussed his MRI scan. And we said, yes, you have got arthritis, but there's been lots of recent studies, I don't know if people might be aware of this, but there's been lots of studies recently where they've MRI scanned people with no lower back pain. So there was a study from 2012, we scanned 2,000 individuals with no lower back pain. And surprisingly enough, over the age of 50, 80% of the arthritis and these are people who are walking around with no pain. And I think that's fair enough to say, is that it's a little bit more complex to that, and arthritis might not be the thing that predicts how much pain we experience. The things we did, we changed. We sort of said, well, actually, we exposed him back into actually moving his body. We did it gradually because we know it's about threat going to the system. So if someone living with pain, if you go and push them and do it too much all at once, the system's going to see that as a massive threat and you're going to experience a massive increase in pain. But we did it really, really slowly. And we used strategies about control. What's one of the best ways to relax people through breathing? So we use breathing exercises to relax it. And over a period of time we started moving.
Can I just ask you something? You know, them 2,000 people who you tested and they didn't have the arthritis, but you didn't. Don't you find that some people have a low pain barrier, I do, and some people have a high one?
Yeah. You write that down, we'll answer that question, and we will answer that question. You write it down and we'll answer that question, yeah. Things he believed. We actually, the stuff what Dr. Barker's talked about, we spent numerous sessions talking about the complexity of pain and how this is perhaps about the nervous system. And what I remember as a clinician, someone saying, patients can't understand about pain, it's too complex. But there was another study what was done which was showing that patients can understand pain, and knowing about pain can actually reduce threat and also can sort of improve the way people manage it. So we talked about pain, 2 or 3 sessions, actually more than 2 or 3 sessions, we took numerous sessions talking about pain. And over a period of time, as he improved his function, he was able to sort of expose himself back into going into his garden. And the good thing about going into his garden is that was his way of relieving his stress. And when we think about fall, one of the things what winds up pain is stress. So we sort of counteracted that by getting back out into his garden. And over a period of time, he was able to get out, go to coffee with his friends and walk around the block, and he built it up really slowly. And people in his life, what was really interesting is he brought his wife to one of the sessions because he wanted to say, I want to get her on board with this as well, because it's really difficult when you're living with a loved one and you're in pain and perhaps they're not in pain. So he felt it was really important for his wife to understand it, and he said that was massively, massively important. And things happened in his body, and over a period of time he felt less anxious and his mood improved. And I wouldn't say that this fellow was he wasn't pain-free. He still lived with an element of pain, of course he did. But he told me the big things is that, he said, I understand the pain a lot better now. I've been able to engage back in activities what I enjoy. And he also says, I no longer have to go to A&E when I feel my pain, because I feel I've got strategies I can do myself. And I thought that was really, really important. And I was doing this case study, and I hadn't seen the fella for a while, and he actually rang up the clinic this afternoon, and he spoke to our excellent secretary over there, and he rang up and he said, I went on my bike today, there's 5 miles on my bike. And that's what it's about. It's about improving quality of life. If you can improve pain as well, brilliant, and often you can, but it's about improving quality of life. And improving quality of life will have a real positive impact on pain. It really is. Can you go, how long have we got there? 10 minutes. Can you go back to the... Chris, do you want to add anything on the case study? Oh.
I think what strikes me, Graham said something at the very start about courage, and about the courage to be able to do something different. And I think part of the courage, I think, also has come from the clinician. Graham doesn't know probably what I'm about to say, but I think having the courage that Graham has as a clinician to be able to say, do you know, if we think differently on this, actually we can work differently, we can get a different result. And as a clinician, sometimes we get so conditioned into saying, if that makes your pain worse, then it's the wrong thing to do. And it's so important that we know that sometimes the wrong thing is not the thing that flares pain, but it's not doing that, if that makes sense. And it's sometimes about getting the dose right of these kinds of things. So as clinicians, I think we often, as I say, get conditioned into playing it safe, and the safe option is not to challenge these kinds of situations. And when we don't challenge the pain system in this way, then we don't get very far. And I think it's he doesn't know what I'm going to say. There's great credit to our brain.
And I think what Chris is saying there, I think from a physiotherapy perspective, really speaking really honestly, I think if you look at the research, I don't think over the years, we haven't done a particularly great job of managing things like lower back pain. We really haven't, because we've been coming in from the wrong angle. And I think what we're trying to do now as a profession, we're trying to change the way we look at pain and look at things where what is flexible in people's lives. Arthritis, that is what's going on inside your body from a structural perspective. Unfortunately, we can't change a lot of that, but the things what we can change is the thing around the nervous system. And I think if you just go back the other slide, yeah, because ultimately when I'm thinking about pain and management, I think it's about changing the stuff what's going into your nervous system, what suggests that there's threat going on, and creating more of a safety message going on. And I think there's loads of different ways we can do this as clinicians, whether that's a physio, whether that's a psychologist, whether that's a doctor, but things we hear, like I talked about before, when we're explaining results of scans, sort of explaining in relation to how normal it can be for other people as well. So that can change sort of this threat perspective to a more positive perspective. I spoke to a gentleman this afternoon who was telling me about his pain, and he went to A&E and was told really scary messages, and he stopped moving. And then he heard about he spoke to Dr. Barker, he spoke about pain in a different way, and he was able to get on a different journey and a different path. Things you do, staying at home, only taking pills, that is threatening to your system. Creating a more positive thing, gently exposing back into exercise, learning about pain, coming into these events. Things you say, it's just age, it's just fibromyalgia, I can't do anything about it. Well, actually understanding there is things, the system can be so flexible. Things you believe, pain is forever, it gets worse with age. I don't think that at all. I wouldn't be stood here and think that. I do think pain is flexible, and pain does not. Think about a broken bone, it heals after 6 months. The pain is no longer indicator. Places you go, A&E when your back pain flares up, that is a danger message. Going to a dancing class with a friend, more positive stuff. People in your life, up-to-date healthcare professionals who understand about pain. And I know that it is changing. I know they do back classes in here where they talk about all these great things and trying to change the way that we look at pain and things happen in your life. Making a plan, having goals, working with professionals. You've got, I think psychologists said to me, it's a long day on the golf course and you don't know what you're going for. So you know what our goals and working them with us as clinicians. So we're just finishing off now, just my final thoughts. So I think, touching on what Chris said before, I think living with pain, I understand, is incredibly difficult. And to change the way we're sort of looking at managing it as a patient, I think it takes huge courage, because it's never a perfect path managing pain. It's never sort of an upward trajectory. It goes up and down. But I think as long as we're going in the right direction and we're trying to change the drivers of pain rather than the symptoms of pain, I do think there's hope to change pain. And I think as clinicians and people living with pain, we need to change the way we look at it. So having these events and sort of spreading the word, I think, is massively important. I'll let Chris just finish off.
I don't really have much else to say, really. I think have a think, and honestly, please, if there's questions that this brings up, and you kind of think, I can see that, well, that doesn't stack up for me, that doesn't explain things for me, scribble it down, please do, because we will be looking at these questions as we go through this evening now, and we'll be looking at what we can kind of discuss at the very end. So honestly, that's great feedback for us to be able to understand all the issues. But yeah, I think it's probably break time now. Have a kind of stand or have a stretch and have a drink and have a wander around and just have a chat with other people. Thanks very much.
Thank you.